then this button. Then we go over here. And we go over here. And we go right there. Yay! Okay. Here we are. There we are. Okay, real quick. So we'll have an office hour next week, correct? Is that what I put on there?
That's Christmas Day. Is it?
Oh yeah, that's right. We skipped that one. And we'll have the office on the 4th, right? No, wait a minute. I'm in
The
December.
first.
The
Do you want it
1st.
January 1st?
I doesn't matter to me. I'll be on it. If anybody else wants to, I will. It's not unless I'm at my December's birth, I'll be on it.
Well,
And
yeah, that'll be the same for me because she's doing that window.
yep. So we'll just kind of play it by ear and watch WhatsApp, right? Nothing new about availability or school email. Um, okay, real quick check-in. How are we adjusting to the new platform, the new class platform? Is everybody kind of seeing where things fall? It doesn't, it just keeps it in order. I don't know, it's kind of, it's a little different. Any questions about where to find stuff? I'm trying to organize it as best as I can while figuring out how to do it. Once, twice, last call. Okay. As far as I know, I don't have a way to put, I mean, but the link it never really worked for us to put the Zoom link in the platform, so that's not new either, but I don't think that there is a way. Okay, so we mentioned it at the first week we're in person, but we are having an in-house workshop April 2nd through the 4th with Nicole Morales. And then I counted out the potential second in-person weekend will be the end of August. So let's start thinking about that time frame and kind of looking at that time frame. I know that might suck for those of you that got kids going back to school at that time. I'm really sorry. As far as I can tell right now, that is the earliest that we would have it. And just kind of look at the week before, so the 3rd week to like the 1st week of September, kind of see what's going on for everybody at that time. And we'll figure it out like we did last time. Also, our next in-house workshop will be next winter, and that will be our NRP workshop. Okay. So no hard dates on that yet. So just as a general heads up that that's when it's going to be. Okay, any questions about that? Okay. All right, so let's talk about the readings. What did you guys come across? Or what's some topics that you came across in the readings that you definitely want to try, that you definitely want to visit in the lecture?
I guess maybe miscarriages. I know it's pretty
Okay.
broad.
No, that's okay. Okay, anything specific from The readings are just like
Just in general.
just in general too.
Yep, just in general.
Are
I
you
have a question.
wanting? Oh, go ahead. Sorry.
Question for Millicent.
Okay. We will. We'll get into that's yep, that's one of the topics. So we will.
Okay.
Yep, we will.
We'll be, and also will we be covering like what we could incorporate, what we're doing as traditional home birth for like traditional culturally to support miscarriages.
Yes and no, because each of us comes from different communities, so like those teachings would be potentially pretty different. I'm happy to share what teachings have been shared with me. And but as far as like and yeah, we'll expand on that discussion. So support practices.
Yeah, I'm curious because we have so many different tribal people down here. And the only other thing I have necessarily done is with her Roxanne. I forget her last name. She's no longer with us. Millicent knows, but I don't remember. Sasosi? I don't know. That's all I had.
Anybody else on readings? What did you guys come across the readings? So, no new books, but I mean, this is where the part was like, hang on, guys, we'll go back and we'll revisit stuff. Okay. Usually I'd make us sweat out the whole 20 minutes, but I'm not entirely sure that my halfway stopping point that I'm going to fit it all in. That's why I broke it up into 2 lectures. So I'm just going to start going. Okay. So, what does it look like of the things when you're getting inquiries, when you're doing consults, first checkup? What are the things that we're listening for about pregnancy history, health history, that we might want to ask more discovering questions about, more clarification for, stuff like that. So this is that consideration. For myself, it really depends on a lot of it really depends on okay, so the first one, STI, history of STI, STD. Okay, if this is part of their history in their early 20s, and they've already had 2 babies and they haven't had any concerns, and this is the 3rd one, and I'm supporting them their 3rd one, I'm probably not going to be too concerned. I'm probably not going to ask a lot of discovery questions or expansion questions. I have supported women who are on, I forget the name of it, the long-term herpes medication. What is it, Jade? Your genius brain holds on to all those words.
Valtrex?
Valciclovir. Yeah, Valtrex
Yeah.
is the brand name.
Yep. So if they're on that, I'll ask them, how long has it been since they've had an outbreak? Do they know their triggers? Do they feel like they have it well managed and in hand? I'll talk about, what's the tentative game plan if there is a spontaneous outbreak, end of pregnancy, early labor. And that's usually about it that I'll talk to them about that. It is though, it's a potentiality. Like if you don't tell me in the first couple, if we're 4 in and you're just telling me that you're on this now, 4 or 5 prenatals in, or if we're two weeks away and you're just telling me now, I might terminate contract because like it's a big deal. Jade has a personal experience with this particular one of when it was a big deal, and then she ended up having her team ended up having to get tested for exposure. So that
For 6 months.
For 6 months, yeah. So, and some of us, this can be a prevalent thing in some of the communities that some of us are supporting in. So, some midwives, this is a hard line. If it's been a thing within, I don't know, last 3 years, last 5 years, whatever it is, since the last pregnancy, within the last 2 years, within 9 months prior to conception, I've heard all of those boundaries in different forms. Jade?
So for me, I've had
Did you freeze? Can't see you.
She
I
froze.
think we were 4 in.
Oh,
Crap.
hold on,
Can you
start
guys
over.
hear
You
me?
froze. No, you froze.
Okay, can you guys hear me now?
Yep.
Okay. So I had two instances with genital herpes. One, the client did not disclose until she was about 4 prenatals in, 3 or 4 prenatals in. And she was like, oh yeah, by the way, I have active herpes lesion right now, and I've had it for 3 months. And I ended up terminating care with her because a few months prior to that, we had a late to care client. And by late to care, I mean like 39 and change. She went into labor a few days after I met her. And she had told us on the 3rd day of her labor that she had had an active outbreak a week before. And then when she ended up transferring for mech and oligohydramnios. And when we got to the hospital and she was examined before they did an amnio infusion, she had active lesions all over the inside of her vagina. And I had given her cervical checks, 2 of them. And because I wasn't, digging around in there with a flashlight looking for an amniocentesis line, I didn't visualize deep in her vaginal vault to see these active lesions. So the team that were there were 3 of us there because it was a very, very long labor. I paid for all of them to be tested over the next 6 months because it can remain dormant for quite some time. But not only was I in her vagina, but we were in the water. She had spontaneous rupture of membranes with MEC in the pool. And so we were exposed to that. And she didn't disclose any of that during our consult or during our first prenatal exam. She only disclosed once she was in active labor. And that's something that doesn't go away, right? Like you're on immunosuppressants for, you know, if you go the Western route, you're going to be on an immunosuppressant for.
Yep.
Oh.
Yep.
But thankfully we all tested negative. But they do think that I might have had more of a primary exposure. No duh. Because I ended up throwing down active Epstein-Barr virus, which is like a cousin of herpes.
Yeah. Part of the conversation, if I am supporting a client and I know this is part of their history, part of the conversation is, well, if you do happen to have one, the recommendation is to labor in water, right? But I won't be sticking my hands in that water without literal veterinary gloves that go up to my, like, I tell them, I'm like, okay, you're going to see me with a glove that goes up all the way to, and I'll probably have a plastic apron on, and unless I absolutely need to, I'm basically just going to talk you or your husband through delivering your baby unless I need to,
I had another gal with cystic fibrosis, HSV 1 and 2, but she took Elciclovir her entire pregnancy, and she agreed to be blue lit, and she did not have any active lesions, and so we supported her VBAC.
Yep. Yeah, so that's an option too. Is everybody any questions about what blue lighting does? If there's any virus, even if there's not a lesion, it'll show up under blue light.
And she did opt for a erythromycin ointment for her baby.
Yep.
Just as prophylaxis.
Yep. So I think that's it for if they have a history of pre-E or ICP in previous pregnancies. Couple things. If there's been pregnancies since she's been labeled pre-E, like if it was her first one, and because you got to kind of suss out, because it's getting thrown, the label's getting thrown around so much in so different many contexts with so many different parameters of like, well, you had one slightly elevated BP, so you're pre-E. So that's where a lot of my discovery questions are going. Okay, was this your first one? What was the conversation around it? Well, what did they do? Well, did you go into an induction? No, I had a spontaneous labor at 40 weeks. Okay, well, then they really weren't that concerned, because if they weren't really pushing the induction down your throat at 38, 39 weeks, this might be an area where I ask for previous charts with notes. ICP, we'll get into this more in a little bit, but my biggest question is, at what week? At what week were you told that you had ICP? Okay, that's going to be my biggest question, and put a sticky note there, because we'll expand more on why that's my biggest question when we're talking about it in the next section. Okay.
For me with pre-E, I always ask them, Did you have elevated liver enzymes? And did they offer you a 24-hour urine test?
Yeah. Oh, they didn't say anything about that. They didn't ask about that. Well, then they really weren't that concerned.
And they're not worried about you having pre.
Did you have labs? Did you have an induction? You know, were you on mag? Did you have a mag drip? And like, those are the things like, okay, they were really concerned what was going on versus like,
right.
You know, the nurse took it too soon right after you climbed 2 flights of stairs in an elevator and drove yourself there and it was slightly elevated and maybe she's shitty at taking BP manually and it never got brought up again, but then you got labeled it. So then, you know, their perception of their first pregnancy experience is like, well, I was eclamptic. And then of course, if they had subsequent hospital, she gets that label carries, right? So then she's at risk with the next one and the next one. And then maybe you're seeing her at the third or fourth or second, hopefully, or whatever it looks like, where it's not as big of a label as what's been kind of pushed on her perception, if that makes sense.
I do try to tell primates, especially, that they are more susceptible in a first pregnancy, but it doesn't necessarily mean that's going to carry over biologically and physiologically in a subsequent pregnancy.
Yeah.
And then I ask like, well, did you have a mag drip? Like, what were they doing? Or I'll say, you know, did you have 2 elevated pressures within 4 hours of each other? Because that's the clinical standard now.
Yeah. Did they keep you?
Did they check you again?
Yeah. Did they keep you? Did they check you? Did they not let you leave until the full 3 days after birth?
Right. With the mag.
Yep. So those would be my discovery questions, my follow-up questions if she's telling me that she's like, you know, because right, all the things she got labeled in her first pregnancy, then the next one they saw it on her chart, so then they're like hyper aware and all that cascade. Super fun. Okay, so history of gestational or PMAD or I can't think of the other one right now. Anyway, again, my first question is going to be at what week gestation? That's going to be a big one. Did you have the follow-up glucose tolerance test or did they just like label you after the first one? You know, what did your day look like? Because I've had women who said, yeah, they told me I was gestational. Okay, tell me about that. Tell me about that checkup. Well, I didn't know that I was going to get that test. And I had a bagel. I had a bagel and Starbucks and a half of a muffin on my way over because I was hungry and I didn't know that I was going to do that test. Well, dang right, you're going to fail it. Like, you know, so those are a lot of the questions that I ask. Well, did you have the 3 hour? No, they told me I didn't need to. Well, why? I would die on the hill that that's a brown card thing, and I don't think anybody's going to convince me otherwise. I'll stop that inflammatory thought. Lot of conversation around PMAD. So this is in pregnancy. This is not postpartum, right? And usually this goes right into the next bullet point, the SSRIs. SSRIs are kind of a hard line for me, especially if they're still on it and still planning to be on it throughout pregnancy. And mostly because of I don't have the tools in labor or immediately postpartum. And it's not always an easy, quick transfer situation. Okay.
I will do SSRI, some, not all.
Well, you
I
spent
have,
more time. You spent more time supporting in Utah, where
right,
you have
where
a
it's
total.
capital.
Yeah, you have a totally different experience set than I do. I'm not comfortable with that because, like, I'm just not. Except for like, what's the new like Zoloft quote? Sertraline.
Yeah,
That's the
yeah,
new.
that's Zoloft. Mhm.
Yeah, and um, but we're gonna have a conversation that you're probably not gonna have an easy, spontaneous labor pattern, especially because like I'm starting to experience a lot of younger women who are just off hormonal birth control within 5 years of them getting pregnant and they're already on sertraline. Those can be some wonky, irritable patterns, like really wonky. THC use and LDN use is, I have some stipulations with that. If they do not,
That's a hard pass for me.
yeah. If they don't want to agree to my felony bag, that's a hard line for me because every single one of them that I've supported has bled. Every single one. But like methadone and Suboxone, that's a hard line for me. Whereas
Right.
Jade will, it's not an automatic yes, but like she'll have more conversation about it than I will.
It's not an automatic no.
Yeah,
That's for sure.
It's not an automatic no. But Jade has a different comfortability and experience line with bulldogging in the transfers. And that's probably where you're going to end up. More likely than not, you have a higher chance. If not in the antepartum and labor, those babies struggle. They struggle to transition. They struggle to perfuse. And if you don't either have the tools or, you know, are very clear about your transfer line and very comfortable about your assessment skills with chest retractions and all the things, then just make it a hard line for now. Doesn't always.
Do you know what NAS looks like, particularly in a Suboxone baby? If the answer is no, you should not take them.
Yeah. And proximity. Okay, are you close enough? A lot of times I'm 2 hours away. I'm not close enough. I'm not close enough. And I don't want to be in a situation where I'm basically hostage negotiating at 2 o'clock in the morning, where I know without a doubt, because they're sending me videos. Does this sound normal? Does this look normal? And I'm demanding basically that they take their baby in, and they're basically hostage negotiating with me about my reasoning. So I don't want to be in those situations. So I don't put myself in those potential situations. Okay, if it's someone that in your community that you can, go check on 10 minutes down the road, maybe that's a different consideration, right? IVF is a hard line for Jade. It's not an automatic no for me. I'm willing to have the conversation with them, but almost every single one decides not to have home birth support after I have the conversation with them. Not because I'm trying to actively dissuade them, but when I start talking about all the considerations with the placenta and higher instance of retained placenta and different degrees of previa, I want to know what kind of IVF. I want to know, is it real IVF or are they just on the Clomid shots? Clomid shots, and then they're internalizing that as IVF. Was it an 8-day transfer or 21-day transfer? I also want to have a conversation with them about why you made this huge investment in a successful pregnancy, and then you either think that you can have a low intervention birth or want to risk. So I want to have a conversation about their perception and their headspace too. What about you, Jade?
So for me, IVF is a hard no. I have some religious considerations regarding IVF. But I also tell them, like, look, you're gonna have, like, here's the problems with this. What kind of blast did you have? Did you have a 10-day? Did you, like, what are some of the parameters for that? And I talk with them about some of the increased risks. And I do ask them as well, like, look, if home birth is supposed to be for low risk, you had a high risk conception. It stands to reason to me that you are going to have a high risk birth. Most of these births end in a preeclampsia diagnosis, and some of them go on to be fully eclamptic. Many times they are on different hormonal patterns to keep them pregnant after the IVF transfer itself.
Yep.
And so we talk to them about, what does latent use of progesterone look like? How is that going to affect you? We talk about that when a pregnancy comes from an egg and a sperm and an ovary, it's implanted and fertilized in the fallopian tube. And then it comes down and it implants somewhere, usually along the top of the uterus, unless you've done like Plan B or something like that. When you are implanted with an IVF pregnancy, it usually implants either at, near, or in the lower uterine segment.
Yeah.
Well, that is a big problem for subchorionic hemorrhage. It's a big problem for bleeding before baby and the labor. And a lot of times, these women will talk to me about how they felt very disconnected in their labor. And I have my own thoughts on that, but I do talk to them about, if I'm asked, I will tell them why I don't support assisted reproductive technology of any kind. Not Clomid, not Levitinol, not not any of it. And so, but part of my conversation with that is that those babies often need help as well. They are often born stunned. It is often a bloody mech bath. And they are not told that. They are so desperate to get pregnant that they don't hear what the risks are once they are. And so I do try to compassionately have those conversations. And I mean, I'm not always successful. Once they realize that it's mostly religious reasons, then I get kind of blacklisted. But I do try to talk to them about, like, what does that actually look like? And if you're doing Clomid or any of the other follicle stimulating hormone treatments, Lupron, all of those, I ask them, if you have multiples, they're going to offer you selective reduction. Are you going to take that? Is that on the table for you? And then I have my own thoughts about that, right? So instead of trying to like weed through, because I used to take more IVF clients, which is why I know that all these things occur. But I finally ended up just saying, I actually have a problem with assisted reproductive technology as a general rule. And so I've made that a hard no. But I do counsel a lot of other midwives that take IVF clients. And we kind of consult and we talk about some of the things that I've seen, my experiences in the birth center, and why I don't think that you're ever going to be a good candidate for a out of hospital birth.
Yeah. Whereas I'll have a lot of the very, very similar conversations. Because this is a situation where I would want concurrent care. I want you to have ultrasounds. I want to know at 34 weeks and 36 weeks where the placenta is at and to what degree a potential previa may or may not be going on. I want to have an NST. I want to have a BPP. Like, I'm asking for these things. I'm also probably going to ask that you be in town. So if they live out of town and they're having the Instagram fantasy of having, I want you within minutes of not just a country hospital, but in like the bigger hospitals. Okay. I am going to have a very different conversation about the legal things in my bag. You know, I might ask, I might be like, well, this is a 2 midwife situation.
And
You know,
she may
so,
be resistant to PIT
yeah.
because of the hormones she had to take in order to sync her cycle to get pregnant.
Yep. So then I have a conversation about like I need to potentially dig deeper into my midwifery underground bag to get the adequate tools to ethically support you at home. Like, it's not easy for me to get TXA. It's not easy for me to get these things. Like, and I'm not going to incur the cost of that, you know. And a lot of time, like, the assisted families that I have supported, reproduction sciences, sorry, families that I've supported, were only on shots. I have visited with some families that had like true IVF. And after these conversations, one of them was like, okay, well, you know, we'll get back to you. And then they're like, well, since you would want us to do all these things anyway, we're just going to go with the midwife at the hospital. Like, good. Yeah, I think that's a good choice. You know, so yeah, those are our thoughts on IVF.
Well, and I think what's important to note is that you guys have two senior midwives who are very open about the differences in the practice style and the hard lines. I think a lot of times there's this kind of lack of maturity that I see amongst younger midwives, where if someone says, oh, I don't do IVF, well, then, you know, you're a homophobe or you're this or you're that. And like I've heard, I was like, wait, what? Like that's not what my religious leanings are. That's not why I'm against IVF. But like those things, I think it's kind of a unique situation that you guys find yourself in. Like I will do a SSRI, SNRI, but I don't want to take a THC mom, right? Where Jane has a little bit more experience on that end. And that is something that she's able to provide some wiggle room and to provide support. So I think what I would encourage you guys to do is kind of reflect on where your own practice styles might be. And know that you can be a senior midwife whose practice style about these things may change, right? You may not take pre-E or a gestational diabetes gal or something like that. And then maybe your parameters will change a little bit as you come into contact.
Well, and that's a good,
maybe, you know, but I think that there's this idea that if you don't support everything, that you're not a good midwife. And I think it's important to note that each independent traditional midwife has to come up with her own standard of her scope. Because we don't have a scope of practice set of guidelines made for us as independent midwives. We have to find that for ourselves.
Well, and this just reminded me that 2 months ago I got confronted with a scope that I had not considered yet. I got contacted by a same-sex couple that they said that they're going to do IVF, but when I was asking them more questions, what they're actually going to do is IUI at home with a close friend as the donor. So that's a totally different conversation, right? Because you can buy IUI kits at Target now. So that's a different conversation, you know? And if I would have just responded, and that's not to say that if you respond with just no, that's not something that I support, there's nothing wrong with that. But I wouldn't have known that it's actually not IVF. They're planning on doing an at-home IUI kit. And as far as I know, 2 of them haven't taken, and I haven't gotten a follow-up inquiry. So, but I mean, yeah, that got put on my radar the first time about 2 months ago.
And IUI is still, to me, assisted reproductive technology, and it would still be a hard pass for me.
Yep.
I don't care that they're
So
same sex. I don't have anything to that doesn't even play into my mind, because most IVF families and even IUI families that you're going to support are going to be heterosexual. So
Yep.
so the same sex part of it has nothing to do with it for me. It's all assisted reproduction is what I take on bridge with.
Well, so I had to sit with that and like reflect, like, where does this fall within my teachings? Where does this fall within my belief system? Do I feel like I need to incorporate or answer this within the confines of my belief system? Like, and I don't have an answer for that right now. If they were to message me tomorrow, I still don't have it figured out yet internally. So anyway, RH negative. Okay. I have supported a majority of families, RH negative situations that I support do not want to get ROGAM. So we have the conversations about that. And if they want me to get a hold of ROGAM, you know, that's a conversation too. Like, I need to know ahead of time, and I'm going to have to dig deep into my midwifery underground, and that's going to be a cost to you. So, but we'll revisit RH negative too later on. Yep.
And I now require all of my RH negative moms to get a Unity screen.
Well, yeah, that's if they've had for me too, if they've had pregnancies where they have received within the last 24 months, I would want them to have a screen. I would want to know their titer, like they would have a titer screen. Well, I mean, my first question is, what's your husband's blood type? And you would be surprised how many are like, I don't know, I have no idea.
Well, and the Unity screen is different than the antibody screen. Like, I'll start with the Unity screen first, and then I'll do antibodies. But the Unity screen will actually type baby in utero. And so if baby's negative, then I don't care about ROGAM.
Yep. Yeah. Well, and I would want to know, so if they didn't want to do the unit or foster, I mean, I would probably bring it up later on too. But anyway, I would want to know what blood type dad is, and then I would want to know what the blood type of the last child is. You know, if they had a really hard line of going in for labs for whatever reason, I would want to know for sure those two things. So, okay.
And if they don't know, I want to type dad.
Yeah. And I would want to type the last child too. Yep. If they have such a hard bias that they don't want to do the Unity screen, she doesn't want to go in for titers, like nothing, like that would be probably my bare minimum. Unless, I mean, yeah, probably. Okay. Any questions about any of these before we move on to the next one? Really, the biggest consideration is, are you comfortable in the conversation that do you feel comfortable in the depth of conversation that you will create? Like, do you feel like you're able to suss out enough information that you're comfortable with these parameters?
Where do you guys think you are right now with any of these intake concerns?
I have a question.
Yes. Hit us with it.
So if we, so we're doing home births, not birth center births, but if we're doing home births and they're positive for some form of STI, do we send them to, like, I don't know, the county health clinic or a primary doctor, or?
They have a history of STI?
Well, if we do some labs.
Okay, so if you're saying,
if we do some labs and it comes back positive for an STI.
Are you saying you want to incorporate initial labs as part of your intake?
I don't know. And so my world's probably different from all the other students here. So coming from like a medical office, that's something that was like literally always done. And so that's in my brain, that what comes up to me is like, let's get information.
So you can get
there's nothing wrong with that.
No, you can get some OTC, like CVS carries a basic OTC STI screen. A lot of our communities asking for them to go to an IHS clinic as part of like an initial screening. There's lots of midwives that do an initial blood screening, STI screening, like regardless of their history. That is not out of the way to be part of your initial history or initial health intake. Yeah, that's totally reasonable.
And then if they are positive, what resources do you have available? Do you have a family practice doc that you could send them to? Is there an IHS clinic? Is there somewhere where they can go and get treatment? Are they interested in obtaining treatment? You might be surprised at how many people are like, yeah, I think I'll be fine. I don't have any symptoms, so I'll be fine.
Crazy. This has happened before, and it usually goes away about like 3 or 4 months, and that's like 2 months before I give birth, so it'll be okay. I don't need to go in for the prescription. Yeah, you would be surprised.
I don't want to take antibiotics because I don't want to ruin my gut flora.
Yeah.
But these are barriers that you might have as the midwife. You're going to have people that are kind of underinformed in how these things work, that just because you're asymptomatic does not mean you are negative. And it does not, but you are gonna, or not you may run into some of these things where there's barriers or there's bias.
Yep.
I don't want to take an antibiotic because I don't want to ruin my gut flora. And I said, well, what about your vagina and your baby? It hadn't even dawned on her that if she continued to have chlamydia throughout her pregnancy, that her baby could be affected by it.
Yeah.
All she knew is that antibiotics are bad for gut flora. So she didn't want those.
Yep. And you guys saw in my prenatal bag that I had a OTC drug test. I used to have an OTC STD test, but I used it and I haven't replaced it. I mean, I didn't personally use it. Joking. I used it at a prenatal. Actually, I used it at a postpartum along with a pregnancy test. So, yeah, that is totally within reason. If that's part of your intake, that's totally reasonable.
Make it your standard of care.
Yep.
So, can I ask a question here?
Mm-hmm.
So, as they're learning to establish their scope of practice, would these types of situations be a good place to pause for a moment and consult with another midwife, or just at least have a conversation to flesh out their yes or no decisions on whether or not they're going to, support that particular client?
Yeah.
Sure. I would say do that.
Was it earlier
anything?
Year? Yeah, it was earlier last year. I called up Jane and I was like, "Hey, tell me about this SSRI." And she goes, "Dude, that's an antipsychotic, and if she goes off of it or if she alters it in any way, she's gonna go fucking badonkers." And I was like, "All right, cool. That's a hard no for me."
Yeah.
Yep. And then there was another one that was like, okay, she said she's on this SSRI, and Jade's like, that's not an SSRI. So I looked it up, and it was actually an anti-seizure medication, but she never had seizures. But they put her on it because she had PPD, and now if she ever gets off of it, she will have seizures.
Mm-hmm.
So yeah, if I'm not familiar with, I don't do SSRIs, so I don't keep up on them. So I call my SSRI gal right there.
Yes. And I think that, like, yes, you should definitely think about having a senior that you can bounce ideas off of as a young midwife. But like Jane said, we talk about things all the time. There's things that I call, my MFM friend, or, an obstetrician that I know and trust. If it's something that I haven't come across it before, um, even my own daughter-in-law's recent hemorrhage, I consulted with an OB, I consulted with a DO, and I consulted with like 4 midwives on what I was going to do about that. And I've been at this game for 20 years, but it was something that was, thankfully, I don't have a lot of experience with it. And my spidey senses were up. Jane and I supported her, um, not even 2 years ago. And then here she was having another pregnancy. So I definitely put my feelers out there. And I would argue, if let's say you're 5, 6, 10 years in, if you don't have a group of peers that you could call, I'm going to run in the other direction from you.
Yeah. So
if you think you know everything, I'm out.
As an example, when I was first on my own, if they had a history of ICP, that was a line for me, because I didn't feel comfortable with what questions do I need to ask, what conversations do I need to create, what recommendations do I need to be aware of to support the situation. It's only been in the last like 7 years that I've supported anybody with a history of ICP. Probably 7, 8 years, whatever. It wasn't in the beginning,
Yeah.
I probably had some gals that were on SSRIs that I didn't know about because I didn't have the question Rolodex that I have now.
And they don't disclose it because they don't think it has anything to do with pregnancy.
Well, because they're obese and it's fine. Like, as long as you don't get pregnant in the first like X amount of days, or as long as we titrate off, or they'll say it's fine. It's the same with LDN, but it's also we were just talking about endometriosis excision surgery, and they said it's totally fine. So she got pregnant 6 weeks after she had endometriosis excision surgery, and then she's asking me, like, well, they said it was fine. I was like, yes, because they're thinking you're going to birth in the hospital. So sorry, is that kind of what you're going towards?
Yeah, no, that really deepens the conversation, and just reminding us all that we're always on a learning curve, and to just keep reflecting, and that group of peers, as Jade was talking about. Thank you.
Yeah. Anything else on any of these for anybody? Okay, is my background still okay? The wind picked up here. Is it still not too bad?
Yeah, not too bad, as long as you don't get blown over to Kansas.
No, maybe Nebraska, but okay. So next topic section. So this is things coming up in checkups. Okay. We're gonna clump the first two together. So breakthrough bleeding / subchorios / signs and symptoms of potential miscarriages. And we're gonna talk about all of these in all trimesters. Okay, so we're gonna talk about different aspects of this through the entirety of pregnancy. Okay, This is our long section tonight. You ready? Anybody need a bathroom break or drink break? Because get it now, because this is a long section. Anybody need 2 minutes?
I do.
Yeah.
Okay. 2 minutes. Empty bladders, filled cups. Actually, I should do that too, because my grandma bladder.
Please sit down.
We're taking a quick break, Nikki, so if you need a hand, let me know. Yeah, so you can do it on medium until it's like really sizzling, and then don't put the lid all the way on it, just like most of the way, but have like a little lip there so some of that steam will escape. And then turn it to medium low, and it should be done in just a few minutes.
You guys,
Sorry, I didn't miss
I
that,
made
guys. Sorry.
I made this chai mix. I've been adding it to my coffee. Oh, she's spicy. She got a little kicky kick. Okay. Everybody make it back. Well, I guess it hasn't been to. I can't see everybody on the screen. Did Medina or Cheyenne ever make it in with us?
No, not that I can see.
Okay. Everybody back now? We good? Everybody back?
Yeah, we
Yeah.
should be good.
Okay. All right. Here we go. Okay, so first, determining, is it implantation bleeding? Is it a late period? Is it, or what is it, right? Majority of the time when I'm asking about this is because like she's not entirely sure when she conceived, like when her last LMP was. I'll almost always ask like, okay, well, so was your last period like normal, how it usually is? Well, it was kind of lighter and it was a little bit early and it was really short. Okay, so you might have already conceived, like that kind of a tip off of like that might have been implantation bleeding versus like a normal period, right? Um, you know, on the other side, it was heavier than normal. It was later. Okay, well, she actually might have had a conception
Early loss.
that didn't implant, and then that kind of hyperstimmed her, and then she got really pregnant the next time, right? So, okay, same idea. Like, color, clots or no clots, how much does it taper off? Did it increase? You know, those are the big sussing out questions. Okay. Okay, then questions about ectopic, right? Specific pain, lower back pain, fever. What are the ones I can't think of right this second? Those are the big two. Are you having a fever? Does your lower back hurt? Joint pain that you don't usually associate with your normal with average menstruation symptoms. Stabbing pain on one side but not the other side, like irregularities along those lines.
Every ectopic pregnancy I had an eye sty, and I never had one before or after or ever after. So my eye sty was the tip off for me.
Yeah, that's definitely a you thing.
It's what?
That's definitely a personal you thing. That's not.
I'm abnormal on that. I realize that, but that was typical to me.
Okay. Yep. So any of these, not much that we can do without ultrasound. Like, if you want to know for sure if it was implantation bleeding, if it's, you know, an unsuccessful implantation or one that didn't implant deep enough, or especially if there's abnormal pain, localized fever, that's a refer in situation. I don't know any way around that. What about you, Jade? Pretty similar? I would imagine.
Yeah, pretty pretty similar. I'll tell somebody, like, you know, you could do a quantitative HCG and let's see if your numbers are rising.
Yeah.
But you're going to have to do that over successive times. You can't just do it one time. And so they have to understand that they're going to be going in every few days for this. And so for some women, they're fine with that because they don't want to do ultrasound. But if they're willing to do an ultrasound, then I kind of encourage them to go that route, because an early first trimester ultrasound before 9 weeks is going to give you the most information in one short little span of time.
Yeah.
Right? They're going to measure the pregnancy, they're going to date it, they're going to do all the things. So by the time the implantation comes around, most people, it's 3 or 4 weeks after that, and they're like, "Oh, I was spotting this one day, but it was only like a couple of days, like a few weeks ago. But now my period's late." It's like, well, yeah, you probably have a positive conception there.
Yeah. So this is 9, 10 weeks and earlier.
Mm-hmm.
Majority of the time, we're not in communication with women at this point.
Majority of the majority of the time. I only have been lately, because I fill up so fast. So people are calling me now, like, once the stick is dry.
Yeah. Mostly repeats when they know, like, most of the time. Or, I mean, not to say that this isn't impossible, because if you're working with this family in conception counseling, okay, so not out of the realm of possibility. But yeah, this is that 8 to 10 weeks and earlier that this is really only applicable to, really. Okay, other considerations, molar pregnancies, usually 14 weeks and earlier. Most of the time it doesn't really get considered, I would say, until that 10 to 14 week, because it's just assumed to be normal implantation. And what this is implantation happened, but there was some sort of genetic failure in placental development. What would become the placenta? It didn't get to that part. It was the so after the cell division happened, then implantation, and then at some time
there's
frame,
no embryonic development.
Yeah, no fetal development started. This is in that short amount of window when it's just the tissue development that started that would then become the placenta, but it didn't get to the point where it turned to the inner ball of cells and the outer ball of cells, which then the inner ball of cells becomes fetal tissue and the outer ball of cells becomes the placenta and the membranes. Okay, so it's that small window of time that something just didn't line up perfectly because of all of the biological checks and balances, and that's what a molar pregnancy is. Okay. Potential, like this could be a place for a conversation for genetic testing, because if it's happened a couple times, it might be something where their genetic combination that they have a really high instance that this might happen frequently for them. Okay.
And I am also recommending a Unity screen for these women as well.
This early?
Yeah,
or that
because
they've had it.
Yeah, if they've had any signs and symptoms, or if they've had like a blighted ovum before,
Yeah.
I recommend a Unity screen because it's doing all the genetic testing for like 70% of the MBS.
Okay. Yeah.
Plus chromosomal abnormalities, like all kinds of stuff they're finding out, and it's easy.
Nice. So then blighted ovum, usually I would say 16 weeks. That might extend it out to 16 weeks and earlier. It's very rare for this to get past that 15, 16 week. If it does, then that's a concern. This can be a source of quote unquote late early spontaneous loss. But if they never had a ultrasound, they don't know that this was what was actually going on. Okay, so implantation development happened, and then when those two layers, the outer layer started to develop, but the inner layer, there's no fetal development. That inner layer of cells that would then become the embryo, no, the fetus, did not start to develop. So no fetal tissue, no fetal development, no fetal structure. It's just a implantation and a bag. It's actually not even really the placenta.
Just a gestational sac.
Yep, it's just a gestational.
No yolk.
Yep. So no heartbeat, nothing. Okay. This can also be both of these could also be if they never had any ultrasounds dating, if they got past the 10-week, blighted ovums can be missed at the 10-week ultrasound. Molar pregnancies usually are not missed. It looks like a cluster of grapes. It's very distinct. This can be like, yeah, I was pregnant, but then I started bleeding really heavily at 14, 15 weeks. And it was very painful and it was super heavy. And there was a lot of molar pregnancy would probably have a lot of clots passed. A lot of blighted ovums would be a lot of heavy bleeding, not a lot of tissues because no tissue development happened. Okay. Fetal development. Okay, this can be where second trimester loss happens. Again, checks and balance didn't check and balance. This was my personal experience of supporting a 17-week loss was the structures on the left. Okay, so the intestine started to develop up into the inside of the umbilical cord, and the pregnancy self-terminated because the biological checks and balances. This, not to say that these fetal developments can't sometimes result in a term pregnancy. They can, okay, but this can be those 17 to 24 week losses. This is some of the things that can, it's usually fetal development related that is not sustainable to life.
Right.
Okay. This, not to say that this couldn't be a 37 or 39 week spontaneous loss. Okay. If those checks and balances don't get tripped, you know, this can be an intrauterine spontaneous fetal term demise. Okay. Same with neural tube defects. Okay. This, if it gets missed in the early checks and balances, you know, again, same with the like, well, it is fetal development, right? Like, but these, the anencephaly, the endocephaly, the bifidas, they have a higher chance of getting to term and potentially surviving labor.
Yes.
Okay. And then here's the low-lying placentas. Okay, so swinging back, particularly right back to the IVF things too, or stacked pregnancies. Okay, if they're having very close pregnancies and they haven't had more than 5 or 6 regulated periods, not just a period, but a regulated period between the last birth and the next conception, that endometrium might be pretty short, might be pretty thin. Okay. Higher instance of low-lying placentas when they're having very close stacked pregnancies. Okay, because those villi aren't long enough to slow down to the conception, right? So if it's not an IVF situation, or if it's not somebody with very drastic PCOS or very drastic endometriosis, it's probably a stacked pregnancy that you're going to see low-lying placentas. Okay. Accretas are surgical births.
Yeah.
There's no way around it. If you want a live baby, accretas, the total coverage,
And a live mom.
and it's not going to change.
Well, in the accreta, the placenta previa is a surgical birth for sure, right? If you have an accreta, it's where the placenta has also grown in through the uterus.
Oh, sorry.
Like,
previa. I was talking about previa. Okay. Accretas can be very easily missed on the 20-week anatomy scan. Okay. If they have a history of confirmed accreta, but that's where IVF, I would say, especially a 21-day implantation, all have some degree of accreta. You're going to have a sticky placenta. The chances of a manual removal need or an incomplete removal is so high. It's so stinking high. Right? I only have personal experience supporting a marginal previa that moved away. Okay. There again, it depends on what gestational age that this is found. Marginals and partials, super high instance of breakthrough bleeding between week 14 and 18. Okay, if there is a substantial amount of painless, bright bleeding between weeks 14 and 18, you're probably looking at some sort of low-lying placenta that is moving up the neck of the uterus, because that's when a lot of expansion is happening, right? So for most women, week 12 to 16 is when that fundus is finally above the pubic bone, depending on how gravid they are, depending on their bone structure. But that's when a lot of that expansion is happening, and that's when the most placental movement is happening. So if there's bright and painless bleeding in that time frame, it's probably what's going on. Probably what's going on. Only way to confirm it is with ultrasound, though.
And in very rare cases, you'll have a subchoreo that releases during that window. But that also can only be confirmed via ultrasound.
Yep. Here we go. Yep. Okay. I'm trying to figure out where I put your face and it's not blacking. Okay. So subchoreos, Okay. Usually associated with a previa moving. Okay, but not always. Only way to confirm is ultrasound, and can happen at any week gestation. Okay. It can be a marginal, like right along the edge, where just the edge of it, for whatever reason, the edge of the placenta lifted away. Okay, or it could be essential, that just the clot built up and so much that it kind of broke through the edge. Marginal ones, majority of the time when there's bleeding, it's a marginal one. It's not a central one. Majority of the time, central ones are contained, and you're not going to see it until you see the placenta. Okay. But stick that post-it note in your back pocket, because sometimes central ones that do not break through, because what can happen is central ones that essentially drain, that clot, that pool of blood drains. Not all of that placenta necessarily can reattach, but it has a higher chance of it reattaching. Sometimes that can become fully functional again, usually not. Arguable. I mean, these are
A lot of your second trimester losses, spontaneous second trimester losses, so anywhere from 14 to 26 weeks or so, are often due to a central subchorionic hemorrhage, where it essentially, as the body tries to reabsorb it, it becomes a placental abruption.
Yeah. This is usually the route that, if there is a fetal development concern, this is how the miscarriage initiates. Okay. I forgot what else I was going to say, but I think that's about it. Okay. Yeah, I think that's about it. Anything else coming to mind for subchorionic hemorrhages, Jade?
So if you look at the visuals, you'll see where there's a teeny tiny corner of placenta that is not attached to the uterus. In many subchorios, even if it resolves, even if the bleeding resolves, you will see that deadened piece of placental flesh when that placenta comes out. It will be gray, or it will have tons of infarcts. You'll see on the fetal side where the fetal vessels don't go all the way to the placental edge. That's because it was never adhered to the uterine wall.
Yep. If this happens late first trimester, early second trimester, you're probably going to see some circumvallate, because that's not functional placenta anymore. And we will get into the deep dive of that when we do specifically placental examinations. But again, a lot of this you're not going to be able to identify or get the answer until you have the placenta in hand.
Right.
Because even with ultrasound, a lot of that's not going to show up. Ultrasounds they're helpful, but they're not magic.
And all of my subchorio babies have also been IUGR babies, and I have hypothesized for years that it's because they are not getting full placental perfusion, and therefore are then restricted in utero because of that.
Yep, that was the thought that I lost. Is that if they experience a subchorio, especially in later than that 17, 18 week mark, where it's probably the placenta, a low-lying placenta moving, keep it in your sticky notes, because 32, 31, 32, and 34 weeks, you might start seeing signs of SGA or IUGR. And it does, like Twin said, it does have a higher instance of IUGR. And in my few experiences with late subchorios, wonky patterns. Like the contractions are not going to be full bore, because they're and babies might not descend into the pelvis in early labor because they're gonna self-preserve a little bit. You know, like they made it that far. It's that intelligent design. And you might have 45 minutes of fury and a bleed before fourth stage contractions establish.
I just recently had one on I don't know, her baby's like 11 weeks now. But subchoreo did not resolve until 24 weeks, monitored via ultrasound every couple of weeks. At 24 weeks, they could still see like 7 centimeters of it, but it was less than a millimeter of thickness. So it had primarily resolved. But that baby was a 40 and change, 40 and 5 maybe, and was only 5 pounds.
Yeah.
And so definitely, and her placenta,
trash.
Yeah, was,
Sorry.
and this was a repeat client. And Jane and I had supported her with her other baby. And that baby was, 8.5, 9 pounds, was born with a nuchal arm and was a mech bath, but was a big, well-fed in utero baby. And this baby, he struggled to stay in the uterus. We were doing growth ultrasounds, all kinds of things that you normally don't associate with out of hospital midwives, and certainly not with traditional midwives. But we did initiate those things, just because her fundus never got like over 35 weeks. Like it was just, it's kind of precarious for a little while. She did in fact make it to term. She did go into spontaneous labor, but it was a wonky pattern for 3 or 4 days before it finally kicked in.
In the last 2 years, I've had really good results with partridge berry as an herbal support option for term, and only because I haven't had that early. I've used it for suspected placental movement bleeding, so that 14 to 18 week time frame, and I've used it for term subchoreos, third trimester subchoreos. And in all of the instances of full term, I had them also continue to do it in labor as well, because I wanted that clot to stay put. And twice it was very successful, and once it was mostly successful, but only I would ding it points because the abruption expanded, and I would not necessarily say that was the lack of partridge berries help, but she did end up still having quite a substantial bleed, but I would not associate that to the subchoreo that had started in the last 2 weeks of pregnancy. She had some bleeding. Anyway, anything else that you can think of for subchoreos? I don't think so. Oh, that was not as long. Okay, so what do you guys want to revisit? Oh wait, no, I'm not. That was just the first 2. I was like, we're done with that section already?
I have a question.
Yes.
Do they know, is there enough like information on like what prevents subchoreo, or is it kind of something you can't prevent it from happening? It's something that can happen to people. You could do all the things and it could still happen to you. Like, is there any?
As far as I know, other than low-lying placentas, they're not associating it to anything.
Okay.
Okay. Um, I mean, I haven't seen enough to see a pattern, but I mean, anytime that you have a concern of an abdominal strike, you fall, you get in a car wreck, like those are all situations where you have abdominal trauma to where there's external bruising. You have a higher instance of a possible subchoreo, but spontaneous, not associated with a traumatic event. I'm not aware of anything that they're saying is a risk factor. But Jade's the one that keeps up mostly on the research, the current literatures. Are you coming across anything, Jade?
So the only thing is it's with placental development. So that first trimester developing of the placenta,
Yeah.
some people are
That-
saying that there's an associated risk with threatened miscarriage and subchoreo, because sometimes the subchoreo will get larger, like it'll just continue to build. And so then it kind of occludes the space in the uterus, and then it fights for space with the baby, right?
Yeah.
And the baby is not going to win against a solid blood clot. So,
Yeah,
so
because if
think
you
of
look at
it.
these two pictures, the one on the central and the one on the left, like if that clot, especially the one on the left, where that's probably like a 10 or 12-week fetus, right? That clot gets heavier, it's gonna push its way. It's just gonna be heavier than the baby or heavier than the amniotic sac. If we think about conception, right? So what's the contribution of the placenta? Sperm health, preconception health, uterine receptivity, hormone balance. Like
Yep.
the literature and the documents and the OBs are saying, no, that's not it. Like you can't predict those. Okay. But if we're looking at all the things that we've looked at in conception and fertility health, yeah, if your endometrium is thicker, if the implantation happens higher, if the implantation happens deeper, if the sperm contribution is healthier, if the swimmers are stronger, right? But according to OB care, right? They're saying that there's but yeah, if there's that early term bleed and that clot is there, yes, it might open back up. It might get too heavy if before baby gets heavy enough to basically use up that space.
The other thing is I've had some success with false unicorn and lobelia. The problem with that is it's incredibly cost prohibitive now.
Yeah.
And in let's say you have what would be called a threatened miscarriage, you have some unexplained bleeding in the first trimester. If your baby is not chromosomally sound, false unicorn is going to encourage the release of that pregnancy.
Yeah.
If the baby does not have a chromosome abnormality, then false unicorn and lobelia are going to encourage the keeping of said pregnancy. However, as in the case of my gal, she did keep her pregnancy, but it could be argued that she did not grow healthy baby, and she didn't grow a baby with any extra brown fat or any of those things. So from a purely biological perspective, um, what did interfering with that bleeding with false unicorn and lobelia, what did that maybe contribute as far as placental perfusion and things like that? I don't know. It's anecdotal. However, some women don't want to take that because it could help you release a pregnancy, and that's what they're seeking to avoid, right?
Yeah.
And so you kind of have to have the conversation with them about, like, okay, but if you have a baby with a chromosomal abnormality, is that a mercy to be released at 8 or 9 weeks,
Yeah.
as opposed to be born at term?
So
There's a lot of conflict there.
there's a blend called Carry On, and it has false unicorn and lobelia in it, along with a couple other things. And that is the same conversation that I will have with families in early term, like 12 weeks or less. Whatever the body is trying to do, because it's either struggling to keep a pregnancy or it's struggling to release a pregnancy. And that's the conversation that I'll have with them, particularly about that blend, is that blend will help your body do whatever it's struggling to do. Whether, again, it's struggling to keep the pregnancy or it's struggling to release the pregnancy. And it would still similarly do the same if it was the second trimester. But that's not usually the conversation that I start with, because for most women, there's going to be enough fetal development that the emotional component is going to be much, much heavier. And I won't necessarily start the conversation there. I will usually start the conversation with going in to get monitored. Unless they're a home birth or bust family, that's another consideration too. Like, if they're a family that no matter what you say, they're not going to go into the hospital, but you know that about them, then maybe that is the type of conversation that you start with, right? Okay. Anything else on these points of topic?
I don't know if there's any research on statistics on women that actually lose one of the twins. I think the medical profession is just so dismissive, and I'm just wondering if there's any contribution in that to Earl's question.
So disappearing twin, and we'll circle back to disappearing twin when we get to the next lecture when we're talking more about twins. But yeah, disappearing twin, early, one could be a successful development and one could be a blighted ovum. I had that experience with supporting a mom. One, they could have implanted too close to get, like, yeah, there's all kinds of reasons why, if there was two separate conceptions, one might have implanted successfully and one did not. This, not so much why it would be like a missed twin diagnosis, although I guess it could be, like, especially if it's a mono where the cell division hadn't happened yet, or the division hadn't happened clearly, like they're still very close together and the ultrasound just didn't pick up on the separation of it. Yeah, most of the time, from my understanding, the statistics say that when it's a disappearing twin situation, it's usually one successful conception and a blotted ovum or a molar pregnancy, or something. It's, by the time it gets into the second trimester, it's no longer classified, my understanding, as a disappearing twin syndrome.
Yeah, I had one. I'll try to see if I could find the video. I actually dissected her placenta and you could see the other fetus. And you could
Absorbed twin.
Yeah, so the one, I think they were monos. Definitely it was just kind of parallel to the other baby's cord. There was like this weird, at first it felt almost like an infarct, like a little fatty fibrin tissue thing. But the more I looked at it and fiddled with it, the more I thought, oh, this feels like a fetal pole. Like, this looks like a fetal pole. And so we got permission from the family to look into it further. And so we videoed it. And then once we got to where I could kind of flip up what I thought was the baby, and we saw like a little piece of cord. I stopped at that point. I didn't open the little sac itself. Um, and so, but she had not had any ultrasound. This was something that we found in the examination of her placenta. And then she opted for pathology, and it was in fact another baby. They told her that they did not consider that like that it would have fallen under vanishing twin. But what they think was that there was some type of placental abnormality in that region, and one fetus grew and the other one just never fully developed. I don't have any sister. Go find mom or go find dad. I see you're asking for more help. Go find dad.
This can also be a situation where not sure about dates. Okay. If it's an early, 14 weeks or earlier.
Matthew, no tell.
I thought I was
no
pregnant
tell.
Where it was a situation where some of the dialogue might be, well, I thought I was pregnant and I had a positive pregnancy test, but then I had my period and it was like kind of painful, lots of bleeding. But then I got pregnant 2 weeks later. Okay, well, that's not a full cycle. Probably a disappearing twin where one conception released, she was still pregnant. She thinks she got pregnant again, aka Krieger Ulrich Youngbear.
and then she'll have a 37-week pregnancy.
Yeah, that looks like a full-term chunky old man.
Yeah.
Yeah.
A 9.5 pound, 37 weeker.
Yeah. Yeah, my 9 pound, 14 ounce, 24-inch, 37 weeker.
What?
Okay.
Like
Anything else?
what?
Okay. So, HCG and low progesterone. Okay, so real quick revisit. Sometimes why this can be a struggle. If they've recently come off of birth control, body might take a hot minute to be able to self-regulate progesterone levels. Okay, this is where conversation of were you on birth control between these pregnancies, or did you get off of it in the last 2 years, or like how did your cycle regulate? Like tell me about your last few periods before, part of the well, I just got off of birth control and they told me it was going to take forever, but I'm already pregnant 2 months later. Okay. Yeah. So and then here's the gradient of what progesterone needs to be doing. Okay. Mm-hmm. And if you look, when this press really starts happening, right before blood volume expansion, when that placenta takeover is happening. Okay. This is why when I visit with women and they're like, oh yeah, they had me on supplemental progesterone to keep me pregnant. I'm like, what week did you stop? Okay, but if it's not prior to 22 weeks, it's
a problem.
Can be a problem. Can be a problem, right? Because I'm gonna stop that inflammatory. But even if that is stopped prior to 22 weeks, that is not guaranteeing that you're not gonna see concerns with the body trying to produce spontaneous labor. Okay, because if it was suppository or transdermal or oral, like all those are going to have potentially different effects and not predictable. Like how her placenta has been able to recover or not recover from having that supplemental progesterone. Not all women will struggle with a um, irregular contraction pattern. But most will, in my experience, all of them have, but I can't do blanket statements because I'm not willing to challenge the universe in such a manner. But a majority of women do. Okay. Because so if we look at these values, like the HCG, there's a peak. We can see where the peak is at, where the doubling is doubling and tripling, and then it's supposed to drop. Okay, and then that's in correlation. Well, let's see the pattern of how progesterone pattern is doubling and doubling and doubling, and then it crests a little bit and then it drops. Okay, well, I just had a G7 mom that was on 400 milligrams until 34 weeks. Okay, well, this table is in nanograms. This is natural progesterone levels. Okay, nanograms is 100 less than milligrams. And she was on 400 until 34 weeks. At 34 weeks, the natural progesterone level is 134.8 nanograms.
Yeah, so
And
13.48 milligrams. 13.
Yes, 13.48 milligrams. And she was on 400 vaginal suppositories daily before bed because she's 42 and she had a spontaneous miscarriage, and her good-natured, OB friend from the East Coast just wanted to help her out and make sure that she carried this pregnancy to term. And then she's wondering why she's 42 and 3 and not having a lick of contraction pattern. Okay, so yeah, what's the problem? So then I ended up giving her tinctures that were specifically to lower her progesterone, right? Because we need that drop. And I would actually argue that drop needs to happen. That's a sharper drop than this chart. That green line needs to be a little bit sharper in that 41st week. Right? Like that's how spontaneous labor happens. It has to drop.
Yeah, it has to drop.
Okay.
The same way as when you have your period, right? In order to have your period, your progesterone levels have to drop so that your follicle stimulating hormones will kind of come into play. When that progesterone drops is why we often see we give prostaglandins for cervical ripening.
Yep.
It's because we're getting that drop normally.
But if they were recently on birth control, or if they are having progesterone supplementation, because
it doesn't do it naturally.
Yeah, it doesn't do it naturally. Okay. And even though that our OB was saying, oh, well, that progesterone's out of your system. Well, maybe, but that placenta doesn't know how to operate without those training wheels. And that's the functional mechanism problem. Yes, the progesterone that she stuck up her vagina at the 34 week is technically out of her system. But
however,
the mechanism misfire in the placenta is not functional. Right? So please stop taking it by 20 weeks. Please.
Please.
Okay. Okay, anything there? Anything that you want us to go over? Okay, we're all feeling good about this understanding and like how and why to create these conversations. Okay. Now there is, if someone is having concerns about how to maintain or increase their progesterone naturally, this could be a conversation for early herbal support, right? Ideally nutritional support. And I promise we're going to do a deep dive in that. That's in the next lecture. So don't feel like we're leaving you hanging, right? Because, and it's a carryover of the nutritional support for menstruation hormone fluctuations, right? Like the same as the luteal phase support, right? When the progesterone is high and then it needs to drop. Okay. UAs. Okay, revisit on the UAs real quick. We spent some time with it in the in-person weekend. For anybody that wanted to test their UAs. Okay. To coin a Jade phrase, blood and urine don't lie. Okay, it's going to tell us exactly what you've been doing, particularly on your electrolytes, and how your body is utilizing it. Okay, but be very, very, very sure that you can create the functional conversation around, well, I must have too much protein because there's protein in my urine. Well, if there's glucose in my urine, that just means that I have to stop eating all the sweets. Not how that works. Okay, blood volumes and UA volumes are not telling you the same thing. It's actually telling you that you don't have enough in the UAs. Okay, so the two big ones, if ketones are popping up, you're not eating enough. You're in ketosis. And if you're in ketosis, that baby's been in ketosis for at least 4 hours longer than you have been. If you have protein in your urine, you are not eating enough protein, much less frequently enough. If there's glucose in your urine, you're absolutely not eating frequently enough, and you're not eating enough complex carbs and starches. Well, thank you for coming to my TED Talk. Please feed yourself. Okay, those are the big ones, right? Leukocytes, very normal, very common for some women to have trace to moderate amounts of leukocytes in their entire pregnancy, especially if they have toddlers, and especially if their kids go to elementary school, because leukocytes are either trying to stop you from getting sick or they're trying to help you getting over from being sick. Okay. If bilirubin and urobilinogen are coming to the party, it's a bad day. Your liver and kidneys are super pissed, and more often than not, you didn't tell me all of the herbal supplements that you were taking in the first trimester.
Leukocytes may also be if you get in the wifely way a lot.
Yep.
Because your body will actually attack the sperm. And so, like, if I see someone with an increase in leukocytes, I always ask them, have you been intimate within the last couple of days? And they're always shocked.
Yeah.
I know that.
Yep. Well, there again is trying to keep your vaginal tract healthy, clean, right? Okay. pH and specific gravity, you're not being honest with me about how much you're actually hydrating or how much electrolytes you're actually taking. Okay. Trace amounts of blood, you probably got a little frisky, extra frisky. Good for you. Okay, that's my first question. Otherwise, my next question is, are you itching or burning or that's where BV, non-symptomatic BV, and what's the other one?
Mycoplasma.
Thank you. That one. Okay. Yeah. Billy.
That one's no joke.
Yeah, that one's no joke. And yeah, you probably have BV up into the inner Oz, and that's a problem. Bilirubin, you've pissed off your liver so much that we actually might not be able to have a home birth.
Yeah.
So you're going in for labs because you're probably on the cusp of ICP. And they get, the last gal that I said that to, she got mad at me because she was an 8.7. Well, I'm not itchy. Well, 10 is the diagnostic line, so that's right around the corner. So
yeah, you're on your way.
Yeah. You should be walking around at a 0 and non-symptomatic. She was an 8.7 and 10 is the diagnostic line, and she got mad at me because I was right. And I was like, sorry, let's address this. So what did I miss? I think that was my quick rundown.
Nitrites.
Oh yeah. Um if nitrate, there's always something else. There's always something.
Yeah.
You're never gonna see nitrates on its own. Okay.
It could be BV. It could be something as simple as, are you fighting off cold? Have you been sick? Have you been exposed to somebody that's had a bacterial infection?
Yeah, so you're probably going to see specific gravity, leukocytes, maybe a little bit of urobilinogen. If there's enough that nitrites is showing up, UTI, BV, some sort of candida, systemic candida. Yeah,
or GBS. I saw a gal high nitrites. I sent her in. She was colonized for GBS at over 100,000.
Yeah, flaming GBS, or you're on the verge of kidney stones. Like there's something big going on. But you're probably symptomatic and you're probably burning or very uncomfortable when you go to the bathroom in some shape or form by the time nitrites pops up. Yeah, or I mean, we don't like to have the conversation, but you know,
your man stepping out somewhere.
Yeah, your man's getting something from someplace else.
Or you are.
Or they are. Yeah.
Remember Molly?
Yeah.
Molly was jolly. Molly was jolly.
Yep. Molly made many happy. Yes.
Yeah. Molly was jolly. Jolly Molly.
So
that's their own language.
What's that?
Oh, it's literally her name, Molly.
Molly was her name. Yeah.
She was the one that declined for chlamydia treatment.
Yeah.
Because she didn't want to notify all her partners, and it just goes away in a couple of months. It'll be fine.
Yep.
Wow.
Okay, I think that's the general rundown. Okay. Gestational hypertension. So these kind of, the next few kind of build on each other. Okay, so we'll start with gestational hypertension. It's changed to 140/90, but I would say I would argue with that a little bit, because if her first trimester or if her pre-pregnancy normal is like 135/80, and now she's on the verge of giving birth and she's 140/90 and it's the middle of summer, I would not call her hypertensive. Okay. I think you need to take into account the whole picture. I mean, weird that we're a holistic model. I don't think you can just hit the line. I like the old recommendation that if it's plus 20 on the top side and plus 10 on the bottom side,
it's a problem. That's hypertensive.
That's a problem. Okay, I think the old recommendation, and this recommendation just changed like what, 2 years ago, whatever.
Yeah.
But that's also when you started seeing, oh, you're pre-E.
You're pre-E.
I'm like, okay, what does that mean? You're alive? Like, I don't know.
We all are.
Yeah,
that means you have gestational hypertension, but no signs of symptoms of preeclampsia, no increased protein, no HELP, no PUPS, no any of that. But that's right on down the line. Keep on, keep on not worrying about that.
Yep. Okay. Number one factor, hypertension, frequency of eating. Okay.
Magnesium deficiency.
BP is a wonderful tool. It is a small snapshot. Okay, but pattern in behavior is going to sustain that BP, right? For long enough for me to see the BP, the snapshot of the BP, right? So this is the tool of I'm like, okay, how frequently are you eating? Okay, well, every time you eat, is there protein in there? Like, this is the point conversation creating where, like, I'm really pushing the whole frequency and protein load. This is the biggest tool for that conversation. And it's majority of the time, it's that. I would say probably 85% of the time. That's where it's at. Okay. What else? If they have a diagnosis from previous pregnancies, but they didn't do a 24-hour urine, you know, all the things that we were talking about before in their history, then it was probably one isolated incident. And not that I would discount it, but like I would have the conversation of like all the other aspects, right? How's your electrolytes? How's edema? Like, how's your activity?
What
I
kind
had
of
one
magnesium do you take?
Go, please, go.
Because you're
Yeah,
probably magnesium deficient.
what kind of magnesium are you taking? Thank you, go. Love you. I don't need to be kicked in the back. I had one gal that went and hiked at Medora in August and then didn't feel good. So she went to the walk-in clinic and they told her that she was hypertensive. And I was like, well, did you drink anything? Like, you know, I don't know. Anyway, right. So gestational hypertension.
And it's not on here, but I've been really liking nifedipine for
Yep.
gestational hypertension. Part of the reason, my understanding that they don't like it in the facility is that it's not as easy to dose as like hydrazoline or labetalol. And you can have a tackier baby in labor. It takes longer to work. So they're going to give you IV labetalol. But a lot of times I've seen nifedipine, which is the brand name is called Procardia. I've seen that in pregnancy and in the immediate postpartum work better for long-term use than hydrazoline or labetalol. And hydrazoline, they're going to give you that if you're looking like you might be eclamptic, because that will bottom out your blood pressure, and so that's what they're giving for that. If you're just hypertensive in the facility, you get, you know, induced for pre-E or whatever. If you're not on a mag sulfate drip, you are going to be on labetalol.
Yeah, so this would be where asking for charts. And if you see this, then you're like, okay, well, this is a sustained hypertensive state, right? Like, this was stage 2 hypertensive, sustained stage 2 hypertensive state, and they were just praying that you didn't start doing some of the other things, right? Because all pre-E has hypertension. Not all hypertension turns into pre-E. There's unpopular opinion, right? But what do we know? We're just midwives. Okay, so hypertension, and then the other not fun things, right? Swelling, pitting edema, facial swelling, UAs just start looking absolutely gross. Like all the friends pop off, and the urine itself looks disgusting. Your urine strip is like popping hot in all of the squares. Headaches, blurred vision, that whole like system reset, standing up too fast. Okay. You're in a tough state. Okay. Now this can be your hard line of transfer, and that's okay. That's okay. Okay. Probably the first time I ever saw a brewer diet was that one. Remember that one? She was like 210 over something. And we said, you got 5 days. to turn this around, and she freaking hit it. She had
Did it.
200, she had 250 grams of protein a day because she was committed, right? So, but if you're not comfortable with this line, and call it, and that's okay, right? That's okay, because you do have to take into account how much are they willing to invest in their own care, right? You can keep making the same recommendations. You can have a line of like, okay, if I don't see improvement by the next UA, I can't support you at home, right? That's okay, because you're not going to be around every second of the day to keep reminding them you have to have a protein and a fat every single hour, right? Because when we're getting into the deep depths of pre-E, okay, that's what we're really looking at. Okay, I don't mean she's had one hypertensive and there's a little bit of protein, but she's telling me that she had, she hosted Thanksgiving, and there's an associated day of struggle. Like yesterday really sucked, and she was on her feet more, and she, they had cattle branding, and she had a pour, she had to do all the tags, and she had a pour, and okay, there's an associated event with this that's telling me, okay, yeah, your UA is going to look kind of wonky. And I bet you felt wonky. Yeah, I didn't feel too good. And I think I was a little bit dehydrated, and it's, the middle of July. Okay, well, let's get back on track, and I want to see you in a week. And everything is gone and cleared up. Okay, that's not this. Right? This is sustained. Like the last 2 UAs have been hot trash, and she's, I'm pretty sure I'm only getting like 70 grams a day, and no, I can't eat more. I don't want to eat every 2 hours. And so there's, what's the word I'm looking for? You have to gauge, right? Like you do have to gauge. Are they receptive to the concern that you're talking about? Okay,
and are they compliant? Are they invested?
Do they want to invest in putting in the effort to changing this? Okay, and if those 2 are no, transfer care. That's okay. Okay,
Because this can end in death. I think it's like 30 to 40% of cases of untreated preeclampsia will end in either fetal death or maternal death.
Yep.
And that is a real risk. That's not a fear-based just in case.
No,
like
it does.
That's a real risk. And once it gets to severe features, it's very hard to walk it back, even in the facility.
Yeah, it does get.
Can you let Amaris back in?
Oh, okay, hold on. It does get fear-mongered a good amount. Okay, I won't deny that. However, there's legit severity. When it's severe, it's severe. Like it's no joke. Okay. And if they don't value, okay, this is a concern. Like you need the improvement. Okay, but now there's, I don't want to eat so much. All I do is eat. Like if there's pushback and there's resistance, especially until you feel like you get your feet solidly underneath you, make this a hard line. Okay.
And I will tell you that in preeclampsia, the facility will go after you for a delay of care. I've never not had a midwife experience that.
Yeah, in some way. I mean, especially but
I'm thinking that cease and desist. That was a pre-E client.
Yeah. Well, and that, you have to gauge that, right? Like you have to gauge it. So, I had a stop care because she saw on TikTok that cayenne tincture can help with hypertension. I'm like, not in pregnancy, not in this situation.
Yeah.
Like, so I pulled care. What was that, last year? Earlier this year? No, it was earlier this year.
Earlier this year.
Yeah, it was
Yeah.
earlier this year. And why can't I just let her try what she wants to try? So I was like, you don't have time, girl. You're 36 weeks and this is just getting worse. So, I mean, it's a whole picture, but there is nothing wrong with being conservative. If you're not comfortable with the conversations, the recommendation, like, yeah, I don't know what else to say about
And
it.
you're gonna have to police her.
Yeah,
or not, right? Like are you going to do food journals? Are you going to do UAs? Are you going to do, is somebody going to go over there every 4 hours and get her blood pressure?
Well, and that's a consideration too. So for me, distance, I can't hover on you like that. Like I did that with one gal that was in stage 2 hypertension, and she was full term, and I wanted to be over there. I wanted to check her BP every 12 hours, and that was more than generous and more than considerate. And that isn't even what I wanted to do. I wanted to do it every 4 to 6 hours, and I stayed in town. Okay, I camped out in town for 2 weeks because I wanted to help her monitor, because I knew that this was a repeat client. And but then she said that anticipating me coming over at 10 in the morning, at 10 at night, was what was keeping her blood pressure too high. I was like,
no, it wasn't.
Okay.
No, it wasn't, okay. But okay.
Yep. So, and I didn't terminate care at that. I said, okay, well, I'm not coming back until you let me know what you want to decide to do. Okay, these are what I'm willing. Here's what I'm willing to meet you halfway with, to stay home and wait and see. I said, and if that's too much, then I can't support you at home. Okay, so I did no contact for that whole night in the morning, and then she called me back. She said, okay, yeah, we're willing to still do that and have the next conversation about what we need to do. And I put her on a strict carnivore diet for the remainder of her pregnancy. And even that, like, we're literally having that conversation, and her husband walks over with
a latte or something, right?
Yeah, like protein latte or whatever with like chocolate milk in it, and I almost freaking punched him in the face. Like, really? Anyway.
And gestational hypertension is my hard line for everyone except for Jane Youngbear.
Oh yeah, we don't chart that. Okay.
We don't chart that.
We don't chart that. But I mean, the point of both of those stories is, like, I made a concession for who that client was that I probably wouldn't have made for other clients. Okay. But I had to keep checking in with myself. Like, am I willing to meet this halfway? What am I willing to say that I'm willing to do that I'm actually willing to do? Okay. And for her, it was that. Okay. No, she understood she's probably going to bleed. And she did. She understood that, as long as all these other things didn't start popping up in her UA, then I was willing to keep going, as long as, other things didn't start coming up.
Right. And that's where the conversation about the boundaries come in, right? And your comfort level. And are you willing to move the goalposts, and for whom?
Yeah.
Right. Like, I think it's a valid conversation. I think that's traditional midwifery. That's autonomous integrated care, is that you don't have a one size fits all for every single woman. You may need to start out with a one size fits all, kind of like going to the bowling alley and having bumpers.
Yeah.
Right. Maybe you're going to put some bumpers on early in your midwifery career, and then you're going to move the goalposts back a little bit as you're successful seeing these things come to fruition. Right.
Yeah. And this gal that I was making these considerations for was days away from giving birth. Okay, if this would have been in week 34, week 36 even, like even
Right.
her being her, I probably wouldn't have made these concessions.
Yeah, it might have been
Because
different.
I knew she wasn't, we're talking about strict carnivore diet and all the importance, and her husband's handing her a proteined up latte. Okay, what is she gonna do when I'm not around? Right? Okay. But yeah, like it's okay. Like exactly what Jade is saying, you know, and having those conversations. Do you feel as the midwife that you're having sometimes ugly, transparent conversations? Okay.
Yes.
If you're pushing your goalposts like this, like, and this gal actually was at my birth for a while, and she heard some of these conversations that Jade and I was having about my pregnancy, and these were cutthroat, transparent conversations. But that's why Jade was willing to still be my midwife in the situations that I was in, because she knew exactly where my autonomy and my culpability were. And if I'm not 100% sure that this family is transparent, autonomous, and culpable, I won't stick my neck on the line, even with all my experience.
And part of the reason why gestational, you're going to ask people what their hard lines are. Ask them why that they exist. Okay, gestational hypertension is a hard line for me, even after 20 years of practice, because I had a maternal demise. I had a mother die, and it will stick with me forever and ever and ever. And so there are things where I butt up against that line, and I'm like, okay, then that's where you have those kind of ugly, transparent things. There was one point where Jane and I were, I mean, we weren't yelling at each other or raising our voice, but there was definitely a point where it was like, what did you just say? Who are you talking to? And she was like, I need you to just do this thing for me. And I was like, well, then go have a goddamn baby, right? Like, you know, and then she had him like an hour and a half, 2 hours later. But, you know, you have to be willing, A, as the midwife, to know how far can you push, right? Jane and I had other relationship parameters where I knew how far I could push. And at the same time, I had to be really respectful of the relationship being an older sister. There were a lot of blurred lines there, right? So you got to decide as a midwife, are you going to step into those spaces of your relatives, of somebody that has a relational relationship with you? And
Yeah, community member.
is there a power over dynamic then? Right? And can you in good conscience be that for that person? I think it's okay if the answer is no initially.
Yeah.
Right?
Well,
I mean, even Jane and I talked about that. Like, if it was anyone else, we'd have both been like, nope, that's too much now. There's too much stuff going on.
mm-hmm. Well, and part of the unique aspect of some of our conversations that it was, we both experienced full term loss, so we could be transparent in a way that you probably won't be able to with most even community members, and all the different ways that in our community relationships, either blood relationships, clan relationships, like ceremonial relationships, like you do have to take all those into account too, right? And that is definitely something that is unique only to some of our communities, and how we're accountable to each other in those ways. Okay. What was this? Oh, so here's an older recommendation, right? The one thing that I wanted to point out onto this is the patellar reflex. So my preceptor did this in the initial intake because they wanted the comparative. I don't do a patella reflex on the initial intake, but
I don't anymore either.
That's a reason to potentially do it, because if you utilize that as part of your hypertension screening, or not screening, but gauging your
those
hypertension.
parameters,
Yeah.
and you don't have a baseline.
And you don't have a baseline. If they only have like a +1 response, and you're like, oh, that's a diminished response. Well, maybe their early pregnancy response was still only a +1. Okay. Yeah, so that was my whole point on this one. Plus, this is just from an older book. These older books are cool, right?
These older books are so cool.
Right. Okay. So, oh yeah, here's talking about the reflex, right? So if you if this person is, like I said, a +1, and you're expecting a +2, and they're like, oh, that's diminished. Well, I only maintain about a +1 patella reflex all the time.
And you'll see that a lot in people who have done bodybuilding or any kind of heavy lifting, because they utilize magnesium in a different way to support the uniqueness of their musculature, like what the body actually needs.
Yep.
If you're heavy lifting, you're going to need more mag.
I would also say that if prior to pregnancy they had a substantial BMI change for whatever reason, right? Even if it was gastric or sleeve or just
whatever.
For whatever reason. Okay. So if at one point they were operating with, for ease of math, more than 100 pounds of extra body weight, arguably for their frame size, age, whatever, ethnicity, like all the things, right? And then they dropped 75, 80 pounds, and then to get pregnant, okay, their patellar reflex is compromised. It's not going to look how the average person is going to look.
Because it used to support a much larger real estate. And when you look at pregnancy-induced hypertension, somebody in the powers that be decided that that was offensive to women. And so it became gestational hypertension, which you can't gestate if you are not pregnant. So all they did was change the name to gestational hypertension instead of pregnancy induced, because pregnancy induced was woman shaming and blaming, and gestational hypertension means there's no one to blame. It just occurs in the pregnancy.
Yeah, but then all the right, the comfort, the diet,
but the way that you treat it is by helping the mother make different decisions. So
yeah. Well, but then that changed because, right, like in the mid 2000s, like all those conversations stopped, and then the recommendation changed to just deliver, right? Induce and deliver, right? Like they don't monitor, they don't do nutritional counseling, they don't send you to the
because nutritional counseling is mom shaming, body shaming.
Yeah. So I guess we're just mom shamers. Okay, so escalation preeclampsia, right? So hypertension plus ugly UAs. We're in the depths of it.
Sustained liver enzymes, protein in the urine.
Yep. So all the ugly things are popping up on and then, headaches, blurred vision, spotting. Yeah. Okay. I think we're
and there's some preeclampsia going around right now where people are getting diagnosed and they do not have any edema. It used to be, remember, if you had somebody with gestational pregnancy induced hypertension, you were looking for swelling in hands, feet, and face.
Yep. That used to be the
recommendation for looking further, either doing a protein, 24-hour protein, doing a creatinine albumin ratio, looking for elevated liver enzymes, looking for protein in the urine.
Yeah.
Now they're saying any raised blood pressure.
Yeah,
With
it's becoming very rare for me to hear women doing a 24-hour UA collection. It's becoming very rare for me to hear that they're having any associated blood work. It's becoming very rare for even the initial follow-up UA with once they have one high reading. Most commonly they're like, oh, okay, we'll sit for 20 minutes, and if it's still high, then that means you're preeclamptic. Like, that's becoming the most common thing what I'm hearing from women's experience, which is hot trash, but that's what I think. Okay,
so we've been trying to educate and say, hey, ask for these things.
Yeah,
because you can have gestational hypertension without preeclampsia, and you can have preeclampsia. We just had a case of this. You can have preeclampsia without hypertension.
Yeah.
She had normal blood pressure levels, and the protein in her urine was like 390.
Gross.
Yeah.
Gross.
But she had systemic involvement. She had headaches with vision disturbances, but she was 117/74 the entire dang time. If I was just looking for gestational hypertension first, I wouldn't have found it.
Yep. I would say that's a dang unicorn, and you're probably going to be very rare for you to ever see that combination.
I've never seen it before.
Yeah. Okay, so hardline for me, hypertension before 20 weeks.
Yep.
Like sustained hypertension before 20 weeks. Now, it's not very common that I'm going to have a lot of prenatal checkups prior to 20 weeks, because majority of the time I tell families that we're going to establish in person around 14 to 15 weeks. Okay, but if she had OB care prior to this is a reason why I might ask for charts. If our first visit together is around 20 to 24 weeks, okay, and then I'm like, and what she's telling me about her prenatal visits with the OB, if I'm hearing a pattern, I might ask for those charts and like be like, we need to talk about this, and now we're gonna do a diet review, and then you're gonna test your glucose for me for a week, and we're gonna do all these things, and it's still not guaranteeing that we're gonna continue care. But I need to rule this out, definitely. Right. Any questions about hypertension, preeclampsia before we move on? Oof. 9 o'clock already. Okay. Hyponatremia.
Low sodium.
Yep. More common than hypernatremia in pregnancy. Okay. Possible, but not probable. Okay. Unless you're dealing with CrossFitters.
Yeah.
Okay. So low salts, low sodium, low electrolytes, right? To the point where your brain can't function without salts. And sometimes if they have a history of being labeled pre-E or and well, I don't want to swell. No, I'm not eating any salt. I'm not putting any salt in my food. I'm not cooking with salt because I don't want to swell. I don't want to swell up this time. Okay, so sometimes it could be associated with like the distinctive choices, limiting choices because of those previous experiences, right? Well, I make sure that I'm getting 180 ounces a day. My urine is always clear. I make sure my urine is always clear. I'm like, can we not? I actually don't ever be clear. What do you mean? I want to make sure I stay well hydrated so I don't swell up, and no salts, no sodium, no carbs, No added salt. I don't cook with salt. I don't drink any sports drinks. Like, well, actually, can you? Like, let's do that instead.
Yeah.
So,
Please and thank you.
yeah.
And I try to tell people you can have an electrolyte imbalance in the other way.
Yes, you definitely can. Yep. Yep. But hypo definitely more common than hyper concerns in pregnancy. Okay. Especially if they had HG for longer than 12 weeks. Okay, because when HG is sustained, their body is struggling to accept the to acclimate to the hormone changes, right? Like that's as far as I know, that's still the current leading theory as to what is a driving cause of HG that lasts past the first trimester is that
Yeah, you're
especially if this
basically allergic to your pregnancy.
yeah, you're allergic to the hormone shift. Thank you. That's the best way to say it. Is you're allergic to the hormone shift. And if they don't have a Z-Pack or, are getting into this mind space of like, all I can keep down is Coca-Cola and saltine crackers. So don't tell me to eat anything else because that's the only thing that doesn't make me throw up. That's still a hard line for me. Like, no way. Sorry. You can't have a home birth. I wouldn't touch that with a 30-foot pole.
I had severe HG where I literally could keep nothing down besides avocado and buttered toast. But my hemoglobin was a 4 going into labor, and my hematocrit was a 14.
Don't call me. I don't want to be everybody.
Yeah. I opted for a hospital birth with that baby.
Yep.
For all the reasons, right? Like it would have been
for
unethical. It would have been unethical for me to have a home birth.
Yep.
And I literally, all of these things, jaundice, extreme fatigue, tachycardia, my resting heart rate right now is usually in the 120s.
Yeah.
And if you push on my skin enough, you'll see that I'm jaundiced almost all of the time. And it is a throwback from my pregnancy with that baby. I have permanent liver dysfunction because I left it untreated due to my own stupid pride for 27, 28 weeks.
Let's talk about bias and ideologies real quick, eh?
Yeah. Yeah. Let's talk about when your ideology becomes idolatry.
There you go.
We're seeing a lot of that now too. And
Yeah,
there's no other reason why I did what I did.
Yeah.
Looking back to it, is there any midwife coaching that might have helped you shift on that, or is that just where you were at the time?
No.
No, my friends were all free birthers.
He was already, yeah.
Even though many of us had midwifery education, and I was a home birther bust. I had successful free births. I had a successful unassisted pregnancy. And it wasn't until I was facing my own mortality that my husband was like, you're getting the blood and the iron and the bone marrow and all the things, or I'm going to divorce you.
Mm-hmm.
And I had to confront this ideology of trust birth, that the baby figures it out, that everything will be fine, that these are rare instances, so they must not really exist. And I had to finally say, is it ethical for me to continue to live within this ideology that I could have a free birth if that meant I died in front of my family? And so I opted to have a hospital birth. I still ended up having my baby unassisted in the hospital because my husband locked the door of the bathroom and we didn't let the midwife in. But I was there for their tools. I didn't need help pushing out a baby. I was there for everything else. I was there for blood products. I was there for monitoring. I was there for my baby that I knew was very, very small. I was 42 and 5 and my baby was 6'12". He was just as sick as I was. And it was because I was prideful and I had allowed my ideology to become idolatry. There's no other polite way to say that. I put myself and my baby at risk because I didn't want to be involved in the facility because I was a home birther and I was a hands-off midwife and I was a, whatever kind of midwife. And I got humbled very, very quickly in that pregnancy. And it was my last pregnancy, even though that was not my plan. So I sacrificed future children for my ideology as well. And I have chronic, lifelong health conditions now because I did not seek treatment earlier in my pregnancy. And I did not have ears to hear. I had other friends. I had obstetrician friends that were like, Jade, what the hell are you doing? Like, come on, like, get off your high horse, get off your free birth horse. And I didn't, and I pay for it still. So I'm very careful when I talk with women about that kind of stuff because it's only rare until it happens to you.
Yeah. Any other questions about? Oh, okay. So HELP syndrome. Okay, so escalation. Now your liver's trying to shut down. So
and it's a bad day. Please do not attend a woman with HELP syndrome at home. Please.
Yeah.
Please.
Yeah, and I would
please let this be your hard line forever.
Well, and I would be very cautious with somebody that has a history of HELP syndrome as well. If they haven't had an uncomplicated pregnancy and birth, between that one and this one, okay, or unless, I mean, as a baby midwife, no, but maybe now I might make a concession to have a conversation about a tentative plan, but that's a co-care, that's a collaborative care situation. That's not a, and
I ended up with everything here except for elevated liver enzymes. My platelet count was an 85. And my red blood cells, that reference range is like 3 to 5. I think my red blood cell size was like a 2 point something.
Yeah, this would probably,
because I left it untreated. That none of this had to happen to me.
Yeah, this would probably be a conversation that I'm willing to have probably in the last 2-3 years, not even that long. And that's not even saying that I would still do it. I'm just willing to have the conversation.
That's it. Like, what can we do to help you?
Yeah, like, what would it potentially look like? But at any, like, part of that conversation would be like, at any point, I'm pulling the plug. Like, yeah. Because it gets to this point and they can only assist for comfort until you're viable to induce. Like, there's no reversing it. ICP, again, it's only in the last few years that I am willing to support women with a history of ICP. Okay, but that's mostly because, like, the way that I create these conversations about self-care. Okay, big factor of when were you diagnosed? What age, at what gestational time were you diagnosed? Okay, if it was 35 weeks or later, you better be on the boat of all the self-care and all the things, and we're going to do lots of diet counseling, and you got to prove to me that you're doing the self-care. If it's prior to that, I don't know, because this is very reflective of the placenta's ability to still function. If there is an associated 2VC, absolutely not.
Yeah, good night.
Absolutely not. No. Okay, because that is a compromised placenta that will not be able. It's no, because a 2VC is, there's always some sort of fetal structure associated with it. Okay, that baby's potentially gonna struggle to tolerate labor. They're almost always gonna struggle to transition, perfuse, regulate, like, and they're probably going to struggle. They're probably going to fail their CCHD. They're probably going to have some sort of breathing support need. Like, even if there is an actual heart structure that needs to be immediately or soon addressed, it's those bypasses are going to struggle. And if it doesn't, you know, you got a septic baby and you got a septic mom, because that's what ICP is, right? Like, the body is not able to eliminate waste, and by the time mom is symptomatic, baby is already septic. Okay, and this is that itching under the skin. Like, this isn't like topical itching. Oh yeah,
Palms of the hands.
Yep, the itch feels like it's in deep, like you can't reach it. This isn't like dry skin itching. Palms of the hands, bottoms of the feet, then
And
the
you
stomach,
don't get any relief with scratching.
then the face. You know, so yeah. Okay, and then this is a breakdown of weeks gestation, right? So anything in from 36 weeks and later, if that's self-care and not associated to VC, you stop feeding yourself. Your ketosis way too long for too many consecutive months. Okay. Anything prior to that, there's probably a structural concern. There's a placental function concern, absolutely, but there's like that 20-week, I would say probably up to 28 weeks, there's probably associated 2VC or something. You know, because if they're diagnosed that early, that the placenta, before the placenta fully takes over, it can't even regulate, right? Because what happens at 28 weeks? Blood volume expansion and the placenta takes over. That's the big placenta takeover. So that's a structural thing from conception that I would bet you that all of those have some sort of 2VC, some sort of congenital heart thing.
Yeah.
Something. Okay, maybe gastrostesis, something. Right? Pups. Okay, I mean, I'll work with pups. They had it before.
I'll work with pups.
Yeah, I'll work with pups. Like, it sucks. It really freaking sucks, and I'm really sorry. And we're gonna try all the home things. Like, you might even actually end up putting banana peels on your skin, but we'll try and make you comfortable.
Yeah, I've had some success with pine tar soap, homeopathic sulfur,
Yeah,
but it's short lived.
yeah.
It's really short
And
lived.
it's usually at the end because it's a histamine reaction to the final hormone changes.
Mm-hmm.
You know,
I've seen it in a post C-section case too once.
yes, I was just going to say that. You know, that's that's a histamine reaction from an infected surgical site because of the nurses were CUNT S's, S, all the S's.
Yeah.
Okay. Any questions about that? I'm trying to get it to the 10-minute mark. Okay, so quick on the polyhydramnios, too much fluid. Okay. Depending on when this is going on, it is possible for things to regulate out. Okay, but there's a pause. Ask Riker. There's a pause in fundal
I was gonna say, ask Shane how we know.
Yeah, there's a there's a pause in the fundal. Like I got to I don't know, what did I measure, like 32. My fundal was like at 32, and then it didn't gain until I was hit 32 weeks, and then I started to gain again. So it regulated itself out. But I also have a history of two multiple conceptions. I mean, so there's like, and I'm a grand mal tip, like, okay, so it's not an isolated incident. I'm not on meds. I'm not, I'm not on blood. I'm not on hypertension meds before pregnancy. I've seen that. Um, yeah. I don't have type 2 diabetes prior to pregnancy. So you can have small windows of poly and then it regulates out. Okay. Again, seasonally too. Like if you're most pregnant in the middle of summer, okay, thank you. Thank you for having a little bit more fluid to temperature regulate your baby. Thank you, body, for being smart to do that. Okay.
Yeah.
Now, okay. And then so here's some other considerations, right? So NSF, like these, if there's a structural concern with baby, that's the body trying to, okay, this pregnancy snuck past all the checks and balances. Now we have to figure out a way, like now we're invested, now we have to figure out a way to like get to the end, so that can be, there still could be fetal structural, fetal viability concerns, high drops. That's not one to mess with at all. Okay. So this could be, if you have the resources, this could be a case where a post 20-week anatomy, like this could be a BPP. This could be a good reason to ask them to do
Or
it.
follow-up ultrasound.
Yeah.
To
Yep.
assess single deepest pocket, or AFI.
Yeah. Yeah, this could be a good reason to know what the AFI is. Okay. If it's not any of these things, or if they don't want to do those things, do not prematurely rupture those bags. That further tells you do not do an AROM. If you think that there's any chance that there's like some gradient of poly, please don't do an AROM until, like, ever, but like especially not with like a -3, -4, even -2, like honestly. Okay, because there's just so much fluid, it never stops. Even if that baby is well applied to the cervix and she's like dilated to an 8, there's so much fluid. Like, okay,
You need one thing to upset that apple cart.
yeah.
That's
Yeah,
it.
and if you don't know, and it's like a bifida or an anencephaly or a Downs baby that has a heart associated heart condition or an undiagnosed 2VC, like there's a reason why polyhydramnios might develop later in pregnancy, because like it's trying to actually create more of a cushion so that baby can tolerate labor contractions.
Or you have a little boy who has hydronephrosis, and so
Yeah.
his kidneys are overactive because towards the end of pregnancy, your amniotic fluid is mostly urine and things like that. So if you have a baby that has some kidney issues and you're getting some late stage poly, um, those are things to watch for, because he may not have the reserve to go through labor, and the body is, like Jane's saying, it's in this um, position of really trying to, it's protective mechanism, but it can definitely be dangerous.
Mm-hmm. Okay. On the flip side, low. Okay. Mm, I would say be cautious is associating low with post term. right? Don't
Yeah,
just
yeah, I don't.
babies post dates. Don't assume that you're. Don't equate post term, which is different than post dates, as oh, there's gonna be low fluid. No, if you are again. Post dates is different than post term, right? So fetal reactivity is going down because you're starting to suspect post maturity syndrome because of post dates, or sorry, post term,
Post term.
not the same as post dates. And now there's a drop in fluid level. I would transfer that baby. I would transfer antenatally before,
Yep.
before labor.
And I would recommend an immediate induction.
Potentially, yeah.
Oh, wait, we did.
Oh wait, we did. Yeah. At the bare minimum, I would say a BPP like that day. That day. You know, because you're probably on the cusp of post-term spontaneous loss. Yeah, so I'd say I'd argue with that point. Just because you're post-term, don't assume that you're gonna always see that, or don't accept that you see it just because post-dates, post-term.
Right.
Okay. Yeah, and this is low fluid to the point where they're more than a -2 fundal height measurement. Okay. And not just like, oh, it doesn't feel so squishy when I palpate, but when you're not palpating, you can see the outline of the baby under her skin. It literally looks like you put a baby underneath a thin sheet. Like that's what conserved low fluid looks like. Okay. And not just because like, oh, I think my water's ruptured, and you go over there and you amnicate it, and oh, yep, you're leaking, but it's plugged now because baby's lower. Like that doesn't mean that you're going to experience low fluid just because there was a leak, or just because like you've been losing chunks of your mucus plug for a week. Okay. The body's very able to regulate and regenerate that. Okay. But if you do see it because of those things, don't accept that you're seeing it because of those things. There we go. That's the thought.
Mm-hmm.
Okay. Okay. So, this is prior to 37 weeks. Well, 36 weeks, 37 weeks. I would say that's a conversational. There's some families that I would not, absolutely not before 37 weeks, and there's some I might have that conversation with. Okay, so, and you guys will see this, obviously you'll get these slides, but I want to jump to this. Okay, PROM versus PPROM in the home birth. Okay, any suspected PROM prior to 37 weeks, you're going in to get monitored. Okay, anything after 37 weeks, I will accept a PROM with no pattern. Okay, because, and Jade, can you share that document or that literature that we found? Because we have the literature to stand on that when that happens, even in primates, within 48 hours, 80% of those women have birthed. We have the literature to stand on, and it's not home birth literature. It's
Evidence-based literature. So anytime you hear the word evidence-based come out of a community midwife's mouth, know that she's talking about facility birth.
Yeah.
Okay. So it's evidence-based that 76% of first-time moms that have a premature rupture of membrane with no contraction pattern will go into spontaneous labor within 24 hours. So why are they inducing everyone at 12 or 18 or sectioning them by 18? I don't know, because it's their literature that I'm referencing. Okay.
Yeah.
Of the difference, the 20 whatever percent, those women, 100% of them will begin labor by 39 to 40 hours, and all of them will have had their baby by 48 hours.
Yeah.
That is just the math. Now, the problem where it becomes a problem in the facility is they are doing multiple
All the things.
vaginal exams. They're doing multiple exams, having you walk. They're doing all these things. They are now introducing bacteria into that area where the body no longer has that protective mechanism in the mucus plug or in the chorion. So then those women are developing fevers and chorioamnitis, and then are then, oftentimes having surgical births. But if you put nothing in the vagina, and my particular protocol is 250 milligrams of vitamin C every 4 hours with 400 milligrams of echinacea, and taking their temperature and hydrating. I have had one woman in PP-ROM, but one woman in P-ROM for 10 days. Went on to have a natural spontaneous vaginal delivery, home birth after cesarean. My other PP-ROM, her waters released at 34 weeks. She went to the hospital. She was in the hospital for 4 days. She was 33 weeks. They wanted to induce her at 34 weeks. She declined an induction, left AMA. We monitored her every day for the next 35 and 1. Now, we still went back to the facility and she had her baby in the hospital. But she did have a PP-ROM almost 2.5 over 10 without anything, because vaginal exams. And we did have the conversation with both women, the P-ROM and the PP-ROM. We had the conversation of, if you spike a fever over 99.0, you are going in, because by the time you start to register an infection, your baby is already compromised. And so both women understood that was my position and that was my hard line. And that I would have recommended a surgical birth at that point, because those babies may not have enough leeway for an induction. You can't control whether or not an induction is going to be fast or slow. And those babies, once they're compromised, they're compromised. They're going to go downhill from there. So,
Jay, can you put that in the unit 15? That literature?
Yeah,
okay.
I will.
Or send it to me. Send it to me, and I can turn it into a thing. Put it.
Good night, buddy.
Okay.
Hey, love you.
So I'm gonna kind of blaze through. I'll include these back in the next one, but I'm just gonna kind of blaze through the rest. Well, no, we're not. Okay. I will. We're gonna stop here. I didn't know how. So these will be in the next ones. Okay, January 7th. Same time, same place. January 7th is our next one. Okay. My book question. Okay, you guys have Care of the Well Newborn and the Breastfeeding Atlas. Did you guys get sent any of the breech books yet? I don't believe. Did you? Can someone confirm? Have you been sent either of the breech books yet? And you do not have the placenta guide yet, correct?
No, we don't have the placenta guide. Is the breech one a guide to physiological breech birth?
Yes.
Yes.
I have that one. I don't know if
I have that one. I remember seeing it. It's at home, but
okay, so that one was sent out.
It's a big, thick, hardbound book.
It's not hardbound.
A guide to physiological breech book?
Yeah, it's not hardbound.
The only bound or is the clinical procedure something or other?
no.
I'm pretty sure it's a hardbound.
They've gotten all those books so far that you've mentioned.
The second
except for
edition or
that
the first?
placenta. The placenta one we didn't get because none of us could get it and we had to make copies.
Because I don't think you can get the first edition in this country anymore.
Hold on,
You
you
can
guys
only
have,
get it as a
okay,
PDF.
so can I confirm you guys have this one?
Is that the first edition or the second?
Show it again.
This one.
Yes, they got that.
Okay.
Mine
And
different looking.
I'll go
Is it-
downstairs and get mine.
what edition is that one?
well, I have both of them. I don't know which one I grabbed,
But
but
the
you have
second
one of these.
edition is hardbound.
Okay.
Okay, you have everybody got one of these?
Okay. Yeah. I
Okay.
have that one.
Okay, yes, I have to get the placenta exam guide duplicated. We have Care of the Well Newborn. You guys have the breastfeeding atlas.
Yep.
You
Mhm.
have breech release.
Yep.
Breech release.
Care of the Well Newborn was sent out, I think.
Yes, it was. Yeah, you guys have breech release.
Yeah,
Mm,
because that's from Breach within Borders, right?
No,
I don't have breech release.
No.
Oh no. Yeah, I sent that out.
That one doesn't look familiar to me.
Me neither.
Did you get the
The breech release. No.
I'll have to look at Amazon to see which one, but I do know that there was that one. Yes.
The breech release.
Yep.
Okay, this is
Morales, right?
Yeah,
Yeah.
that was from Rika Freeze or whatever her name is. Yeah.
this one is Nicole's.
Yeah.
This one is Rixa's.
Yeah.
So everybody has Rixa's?
I'll have
Yeah,
to
that's
look
the
when I get home.
physiological guide to breech.
I'll
So
have to
you
look when I
need-
get home.
Okay.
Yes.
Okay. This isn't for this unit, obviously, but okay. I'm trying to get all the books that we need until the next in person.
Mhm.
Okay. I will get my placenta guide either duplicated or I will get it scanned and then you guys can have the digital copy. Okay, so in the class platform, I put on the ongoing client case study folder. Okay, so that's where you'll find all that information. Any questions about what's going on? Okay, we're going to walk you through. Nothing that you guys have to do for your graduation panel is going to be a surprise. This is literally the one where you're going to create the chart for and all your forms. Okay, this is where that information is coming from. Okay, if something gets posted, you'll be notified. If something is required for you to turn in for this, you'll get notified. We'll tell you. We're not going to surprise you with anything. Okay, so that's what that new folder is on the platform. Any questions about that? Okay, that is not all that I had. Oh, I already talked about. Okay, look at the end of August for this next our next in-person training. We're probably looking at 4 days. Okay, the end of August, the last weekend of August would probably be the earliest that we're looking at. Okay, because I counted out the tentative weeks as the units currently stand, and that puts us at the end of August. Okay, I know that might be really ishy for those of us that have babies going back to school. So then let's just look at the first weekend. Let's see what works best, right? Just like how we worked it out last time. Okay, so first weekend of April, we have our first in-house workshop. And then our next in-house workshop for NRP is probably going to be the winter of 2026. So just as a heads up. Okay. Anything else? Yes.
Jane, in Minnesota, the kids are out of school still
Oh, lovely.
because they don't go back to school until after Labor Day.
Mm-hmm.
That's so nice.
Yeah.
Okay, so then the last week of August might be feasible. Okay.
Mm-hmm.
But that would be the earliest because that's accounting if we just go straight through, like if we don't do a week or two off in the summer, like that's just accounting for the number of weeks for the units as they currently are.
Mhm.
But that is the earliest that we would be looking at our second in person is the last week of April or August. Sorry, not April.
Mhm.
Okay, any questions? Okay, and then part of our next in-person one is going to be some skills testing out, but then it's also going to be walking through, again, like your graduation project, like nothing's going to be a surprise of what you guys get for your graduation project and panel. Okay. Okay, let me.
So I have only received one response for those questions for
Mhm.
Sam. Yeah, I need those because I'm going to be calling him for him to start working on that project that we have with him. So, storm just hit hard here. Ooh.
Do it now. Anybody unsure about which one Auntie's asking about? Oh, what the heck happened? Oh, Jay just got slammed with the storm, so she got booted.
Oh my goodness.
Okay. I will put a post in WhatsApp for those of us that were not able to be in right now. Get those questions done. Auntie's questions.
Sam will have my head. No.
Okay, anything else for tonight?
Were we planning to revisit like what day we're gonna have lectures in 2026, or are we just still planning they're gonna be on Wednesdays? We don't have to do it right now, but
I will no, I'll throw the question back up in WhatsApp and we will decide next lecture, January 7th.
okay. Sounds good.
Okay. Oh, here she is. Come on back. Okay. All right. Anything else?
Happy solstice.
Yes. Happy winter's night. We got doings and storytelling coming up, so all right. Otherwise, wait to go stay doing hey, thank you, Den Sagadij. Thank you for your time and the sacrifice of your mind. Love you guys.
Catch me up later, Jane.
What's that?
I said catch me up later because the storm knocked out power and everything here.
You're good. You're fine. Show up on the 7th.
Perfect. I'll put
Okay.
it in my calendar and I'll get that paperwork over to you.
Okay.
Night.
All right.
Bye.
Bye.